Peptides won't save you. The hard truth about longevity medicine. Welcome back to the Science of Ageless Living, the podcast where we cut through the hype and dive into the real evidence behind living longer, healthier lives. I'm your host, Dr. Ethan Hausman Marquez, doctor, teacher, and lifelong student specializing in longevity and regenerative medicine in London, New York, and Zurich. Today, we're tackling a topic that's exploding in popularity but drowning in misinformation: longevity medicine. Specifically, in this episode, we're exposing the myths and focusing on what actually works. If you've been scrolling through social media, you've probably seen influencers injecting peptides, popping supplements, and promising to hack aging. But is it science or snake oil? In this 10-minute segment, The Longevity Delusion, we'll break down the biohacking fantasy versus real clinical longevity medicine, why anti-aging is a meaningless buzzword, and the crucial difference between optimization and risk management. Along the way, I'll call out some dangerous practices like blind stacking, skipping labs, ignoring cardiovascular risks, and overlooking metabolic disease. Let's get real about longevity, because peptides alone won't save you. First off, let's talk about the biohacking fantasy versus clinical longevity medicine. Biohacking has become this glamorous DIY movement where people treat their bodies like tech gadgets, tweaking, upgrading, and overclocking for peak performance. Think ice baths, red light therapy, intermittent fasting, and yes, injecting peptides like BPC 157 or thymosin beta 4, all in the name of turning back the clock. It's seductive. Who doesn't want to feel like a superhero in their 50s or 60s? But here's the delusion. Biohacking often operates in a vacuum, driven by anecdotes and influencers rather than rigorous science. Clinical longevity medicine, on the other hand, is rooted in evidence-based practices from fields like gerontology, endocrinology, and cardiology. It's not about chasing eternal youth. It's about extending healthspan, the years you live without chronic disease. Think of it this way. Biohackers might chase a six-pack and superhuman energy, but clinicians focus on preventing the silent killers like heart disease, cancer, and neurodegeneration. Take rapamycin, a drug that's hyped in biohacking circles for its potential to mimic caloric restriction and extend lifespan in mice. Sounds great, right? But in clinical settings, it's used cautiously for organ transplants because it suppresses the immune system. Blindly stacking it with peptides or other supplements without medical oversight? That's not hacking. That's gambling with your health. I've seen patients come in after months of self-experimentation only to discover elevated liver enzymes or hormonal imbalances they never monitored. That's where the fantasy crumbles. Without data, you're flying blind. Which brings me to why anti-aging is a meaningless term. We hear it everywhere. Anti-aging creams, anti-aging diets, anti-aging clinics. But biologically, aging isn't a disease to anti. It's a natural process involving cellular senescence, telomere shortening, mitochondrial dysfunction, and epigenetic changes. You can't stop it. You can only influence its pace and impact. The term anti-aging implies reversal, which is pseudoscience. No peptide or supplement has ever reversed human aging in a controlled trial. Sure, some like NAD+ boosters show promise in animal models for boosting cellular energy, but human studies are mixed, often showing minimal effects on actual lifespan. Instead of anti-aging, we should talk about age management or healthy aging. It's about mitigating damage from oxidative stress, inflammation, and genomic instability. Not pretending we can Benjamin Button our way back to 25. This delusion fuels a multi-billion-dollar industry preying on our fear of decline. Peptides like GHKQ are marketed as wrinkle-erasing miracles, but the evidence is thin, mostly in vitro or small studies. If you're injecting them without understanding the risks, like potential cancer promotion from growth factors, you're not anti-aging, you're accelerating problems. True longevity medicine uses tools like metformin or statins not to fight aging, but to manage specific risks proven by decades of data. Now, let's drill down into the difference between optimization and risk management. This is where so many people go wrong. Optimization is the biohacker's playground, fine-tuning sleep, diet, exercise, and supplements to squeeze out every ounce of performance. It's great for feeling your best today. Think optimizing VO2 max with HIIT or balancing hormones with peptides like IPamorelin. But it's short-sighted if it ignores the big picture. Risk management, the cornerstone of clinical longevity, is about playing defense against the leading causes of death. It's not sexy, but it's effective. For example, instead of obsessing over peptide stacks for muscle gain, assess your ApoB levels to manage atherosclerosis risk. Optimization might give you a temporary glow-up, but without risk management, you're ignoring the iceberg ahead. This is where I have to call out some common pitfalls. First, blind stacking. That's when people layer multiple peptides, nootropics, and supplements without understanding interactions. Peptides like CJC, 1295, and IGF-1 might boost growth hormone, but stacked blindly, they can spike insulin resistance or even promote tumor growth in susceptible individuals. I've had patients stack 5 or 6 compounds based on a Reddit thread only to end up with thyroid issues they never saw coming. Next, no labs. This is non-negotiable. If you're dabbling in longevity hacks, get baseline blood work. CBC, lipid panel, HbA, 1C, hormone levels, inflammatory markers like CRP. Without labs, how do you know if that peptide is tanking your testosterone or elevating your cancer risk? Skipping this is like driving without a dashboard. Reckless. Then there's no cardiovascular risk assessment. Heart disease is the #1 killer, yet biohackers fixate on peptides for recovery while ignoring plaque buildup. Get a CAC scan or carotid ultrasound. Manage blood pressure and lipids with evidence-based meds if needed. Peptides won't unclog your arteries. Statins or lifestyle changes will. And finally, ignoring metabolic disease. Diabetes and obesity accelerate aging more than anything. Peptides like semaglutide, Ozempic have real benefits here, but using them off-label without addressing root causes like poor diet is delusional. Metabolic syndrome, high blood sugar, belly fat, hypertension, drives inflammation and shortens telomeres. Optimize all you want, but if you're pre-diabetic and not managing it, no peptide stack will save you from an early grave. So, what's the takeaway from this longevity delusion? Peptides and biohacks aren't evil. They can be tools in a clinician's arsenal, but they're not magic bullets. Real progress comes from blending optimization with rigorous risk management. Exercise regularly, eat a Mediterranean-style diet, sleep 7 to 9 hours, manage stress, and yes, consider peptides under supervision if the data supports it for your specific needs. In the end, longevity isn't about defying death. It's about thriving in the years you have. Don't buy the fantasy, demand the evidence. If you're serious, consult a doctor who specializes in this, not an influencer selling supplements. Thanks for tuning in to this segment on the longevity delusion. Stick around for the next part of the episode where we'll dive into peptide specifics and safer alternatives. If you enjoyed this, hit subscribe, leave a review, and share with a friend chasing that eternal youth. Until next time, stay evidence-based. If you caught the opener, we dismantled the longevity delusion, the fantasy that biohacking gadgets and peptide injections will magically rewind the clock. Now, let's get unflinchingly real in this segment. What actually kills people? As of early 2026, with the latest CDC final data from 2024 and projections rolling into 2025, the picture hasn't changed much, despite all the hype around anti-aging breakthroughs. Heart disease is still the undisputed #1 killer in the U.S., claiming around 683,000 lives in 2024 alone. Cancer sits right behind at about 620,000 deaths, with the American Cancer Society projecting roughly 618,000 for 2025. Then we have the chronic accelerators. Metabolic dysfunction fueling diabetes and its complications, around 94,000, 95,000 direct diabetes deaths in recent tallies, and neurodegeneration, like Alzheimer's, which took over 116,000 lives in 2024 and continues climbing. These four, cardiovascular disease, metabolic dysfunction, neurodegeneration, and cancer, aren't rare exotic threats. They're the dominant forces shortening healthspan and lifespan for millions. They're largely driven by shared modifiable factors: chronic inflammation, insulin resistance, oxidative damage, poor vascular health, and lifestyle patterns we can influence. Yet, in the peptide and biohacking world, People often chase mitochondrial optimizers or senolytics while these big killers quietly advance. Peptides might offer niche benefits in supervised care, but they won't override untreated atherosclerosis or rampant hyperglycemia. Let's start with cardiovascular disease, still the reigning champion. The American Heart Association's 2026 Heart Disease and Stroke Statistics Update confirms it. CVD, including coronary heart disease, heart failure, stroke, and related conditions, accounts for more deaths than anything else. In 2023-2024 data, heart disease alone caused over 683,000 deaths, with total CVD-related mortality topping 900,000 plus. Someone dies from CVD every 34 seconds in the US. The main driver? Atherosclerosis. Plaque narrowing arteries fueled by elevated ApoB particles, hypertension, smoking history, inflammation, and yes, metabolic issues. Biohackers might experiment with peptides like BPC 157 for endothelial repair or nitric oxide boosters for vasodilation, but without aggressive lipid management. High-intensity statins, ezetimibe, PCSK9 inhibitors if needed, or blood pressure control, plaque progression continues. A high coronary artery calcium score or elevated LPA doesn't care about your latest NAD plus drip. Clinical longevity means prioritizing proven risk reduction. Get your advanced lipids checked. Manage hypertension too is less than 13080 if high risk. Quit smoking and move daily. Peptides alone? They won't reverse decades of vascular damage. Next up, metabolic dysfunction, the great accelerant. Diabetes directly caused around 95,000 deaths in recent CDC data. But that's undercounting. It's a contributor to hundreds of thousands more through CVD, kidney failure, and infections. Metabolic syndrome, insulin resistance, abdominal obesity, dyslipidemia, hypertension, turbocharges aging at the cellular level, promoting inflammation, endothelial dysfunction, and even brain insulin resistance. Obesity and type 2 diabetes shave years off life expectancy and amplify every other killer here. In longevity communities, we see excitement around GLP. One agonists like semaglutide, which have strong cardiometabolic outcome data, or peptides like MOTC for mitochondrial support. But too many use them casually. Off-label stacks without monitoring fasting insulin, HbA1c, or body composition, while ignoring root causes like refined carbs, sedentary behavior, and sleep debt. The hard truth. Chronic high blood sugar damages vessels, nerves, and organs faster than any peptide can repair. True ageless medicine demands continuous glucose monitoring, resistance training to build muscle, the ultimate insulin sensitizer, and sustainable calorie balance. Skip metabolic risk management, and you're fueling the fire for heart attacks, strokes, and dementia. Third, neurodegeneration, especially Alzheimer's and related dementias. The Alzheimer's Association's 2025 Facts and Figures report estimates 7.2 million Americans over 65 living with Alzheimer's dementia today, with deaths around 116,000, 120,000 inches recent years, ranking at 6th or 7th overall, and climbing. Deaths from Alzheimer's have more than doubled since 2000, while heart disease deaths declined. Why the surge? Cumulative hits, vascular damage from the same risks as CVD, chronic inflammation, metabolic insulin resistance, sometimes dubbed type 3 diabetes in the brain, amyloid, tau buildup, and poor sleep. Biohacking pushes things like lion's mane mushrooms, NAD plus precursors, or experimental peptides like cerebrolysin for neuroprotection. But large-scale human trials for reversal are still underwhelming. Prevention has far better evidence. Up to 40% of dementia cases could be delayed or avoided by controlling vascular and metabolic risks, plus prioritizing deep sleep, exercise, social engagement, and hearing protection. Manage ApoB, blood pressure, and glucose early. That's the real brain longevity strategy. Peptides might support in animal models or specific recovery scenarios, but they don't replace fundamentals. Finally, cancer, the the second leading cause, with the American Cancer Society projecting 618,120 deaths in 2025, following around 620,000 inches 2024 data. Lung cancer still leads due to smoking history, though declining, but obesity-linked cancers, colorectal, pancreatic, liver, endometrial, are rising. Cancer arises from accumulated mutations, immune evasion, chronic inflammation, and yes, metabolic dysregulation. Excess insulin and IGF-1 signaling can promote growth in susceptible cells. The hype? Some in longevity circles stack rapamycin or senolytics to prevent senescence-driven cancer, but human data is early stage, and immunosuppression risks are real. Proven wins: screening colonoscopies, saving lives; vaccinations, HPV, tobacco avoidance, sun protection, and maintaining healthy weight. Metabolic health ties in strongly. Obesity links to over a dozen cancers. Peptides, like thymosin alpha, one for immune modulation, have intrigue, but they're adjunctive at best. Ignore screening and metabolic control, and no stack will outrun progression. These killers interconnect. Poor metabolic health feeds CVD and neurodegeneration, inflammation bridges cancer and heart disease, vascular issues hit the brain. The delusion is thinking peptides or supplements alone address them. Real longevity medicine layers optimization. Diet, exercise, sleep with rigorous risk management labs, imaging, evidence-based meds when indicated. Peptides can play supporting roles. GLP, 1S for metabolic disease have outcome trials, but under medical guidance, not blind experimentation. Face what actually kills. Prioritize cardiometabolic defense first. We've already exposed the longevity delusion and faced what actually kills most people: cardiovascular disease, metabolic dysfunction, neurodegeneration, and cancer. Now, in this deep dive, the peptides that matter, we're zeroing in on a handful of peptides that have real clinical promise in the right context. Remember, the episode is called Peptides Won't Save You, for good reason. These are not miracle cures or general anti-aging elixirs. They are targeted tools that can support specific mechanisms when used with rigorous medical oversight, proper diagnostics, and realistic expectations. Today, we'll focus strictly on mechanisms, not brand names or hype. We'll cover tesamorelin for visceral fat and the IGF-1 axis, the combination of CJC 1295 and IPA-morelin for physiologic growth hormone pulsatility, BPC 157 for tissue repair, MOTS-C for mitochondrial signaling and metabolic flexibility, and ARA 290 for inflammation and neuropathy. For each, I'll explain the core mechanism, who they're realistically for, who they're absolutely not for, the biomarkers I require before even considering them, and the non-negotiable risk management steps. Let's start with tesamorelin. Tesamorelin is a growth hormone-releasing hormone analog. It stimulates the pituitary to release more natural growth hormone in pulses, which then raises insulin-like growth factor 1 levels. The primary downstream effect is enhanced lipolysis, especially of visceral adipose tissue, the dangerous deep abdominal fat surrounding organs. This can lead to meaningful reductions in waist circumference, liver fat, and improvements in body composition. There are also downstream cardiometabolic benefits, better lean mass preservation, modest improvements in triglyceride levels, and in some cases, subtle enhancements in insulin sensitivity when visceral fat is the main driver. Who is tesamorelin realistically for? Primarily adults with documented excess visceral adipose tissue that is contributing to metabolic dysfunction. For example, people with HIV-associated lipodystrophy, where antiretrovirals cause this specific fat redistribution, or in carefully selected non-HIV patients with confirmed visceral obesity tied to fatty liver or early metabolic syndrome. It can be a reasonable adjunct in midlife or older adults who have already optimized diet, resistance training, and sleep, but still carry stubborn organ fat. Who is it absolutely not for? Anyone using it purely for general weight loss, cosmetic fat reduction, or broad anti-aging goals without a clear metabolic indication. It is not approved or supported for obesity in the absence of specific visceral fat pathology. It should also be avoided in anyone with a history of active malignancy, IGF-1, can promote cell growth, pituitary tumors or dysfunction, uncontrolled diabetes, pregnancy, or severe liver disease. Biomarkers I require before prescribing: comprehensive metabolic panel with HbA1c below 6%, fasting insulin, ideally under 15 nemu/ml, baseline IGF-1 in the age-adjusted reference range, not already elevated, normal liver enzymes, full lipid panel with ApoB, preferably under 90 mg/dl, and objective quantification of visceral fat, either via DEXA, abdominal CT, MRI, or at minimum a very high waist-to-height ratio with elevated liver fat on imaging. If any of these are off, we don't proceed. Risk management: monitor IGF-1 levels every 4-6 weeks to prevent supraphysiologic elevation, which carries theoretical long-term cancer risk. Watch for side effects like joint pain, peripheral edema, or carpal tunnel syndrome from fluid retention. Always combine with lifestyle, progressive resistance training, and a low refined carb diet, so you're not relying on the peptide alone. Long-term use should be reassessed every 6 to 12 months. Next, the combination of CGC 12.95 and ipamorelin. CGC 12.95 is a long-acting growth hormone-releasing hormone analog that extends the duration of GH release by binding to albumin. Ipamorelin is a selective ghrelin mimetic that triggers short, sharp GH pulses through the growth hormone secretagogue receptor. Together, they recreate youthful, pulsatile GH secretion, multiple daily spikes with natural feedback inhibition, rather than the continuous, supraphysiologic exposure you get from exogenous, recombinant growth hormone, which can downregulate receptors and raise prolactin or cortisol. The result is a more physiologic increase in IGF-1, supporting muscle repair, fat metabolism, collagen synthesis, and recovery without the flattening of natural rhythms. Who are they for? Patients with confirmed growth hormone deficiency, for example, post-pituitary surgery, radiation, or severe age-related decline verified by stimulation testing. In a longevity context, they may be appropriate for individuals with sarcopenia, poor exercise recovery, or low physiologic IGF-1 who have already maximized sleep, high-intensity training, and protein intake. Who are they not for? Anyone with a history of acromegaly, active tumors, IGF-1 signaling can fuel growth, or those using them recreationally for bodybuilding or performance without medical oversight in labs. They are also contraindicated in uncontrolled hypertension, pregnancy, or active proliferative retinopathy. Biomarkers required: baseline IGF-1 in the physiologic range, typically 100-200 ng/ml depending on age. GH stimulation testing. If deficiency is suspected, full hormone panel, free testosterone, thyroid, morning cortisol, HbA1c under 5.7%, and low inflammatory markers. CRP, 1 mg/l. Retest IGF-1 and glucose tolerance every 4-6 weeks initially. Risk management: keep dosing conservative to preserve pulsatility. Avoid high continuous regimens that mimic abuse patterns. Monitor for transient side effects like flushing, headaches, or mild prolactin elevation. Cycle off every 3 to 6 months to assess need. Pair with heavy resistance training to amplify natural GH pulses rather than replace them. Now, BPC 157, the peptide derived from gastric juice proteins. Its primary mechanisms include upregulation of growth hormone receptors in injured tissues, promotion of angiogenesis, new blood vessel formation, modulation of inflammatory cytokines, acceleration of collagen organization, and protection of endothelial integrity. In preclinical models, it dramatically speeds healing in tendons, ligaments, muscles, bones, and gastrointestinal mucosa. Who is it realistically for? Individuals with acute or subacute musculoskeletal injuries, partial tendon tears, ligament sprains, or post-surgical recovery, where accelerated soft tissue healing could shorten downtime. In longevity medicine, it might be considered investigational for chronic tendinopathy or gut barrier issues when standard care has plateaued. Who is it absolutely not for? Anyone treating it as a general healing or recovery peptide without a specific injury or pathology. It is not FDA approved for any human use, and self-experimentation carries unknown long-term risks. Avoid completely in anyone with active or recent malignancy. Angiogenesis promotion is a theoretical concern. On anticoagulation therapy or during pregnancy. Biomarkers and prerequisites. Confirm injury with imaging, MRI, ultrasound. Low systemic inflammation, normal ESR, CRP, normal liver and kidney function. Track healing progress objectively with repeat imaging or validated pain function scores. Risk management. Used for short defined courses only, typically 4-8 weeks. Injection site reactions are the main reported issue in limited human pilots. Theoretical cancer risk from angiogenesis remains unstudied in long-term human use, so caution is warranted. Always combine with physical therapy and load management. Never use as a standalone shortcut. Moving to MOTS-C, a 16 amino acid peptide encoded directly in the mitochondrial genome. It functions as a retrograde signal from mitochondria to the nucleus. Under metabolic stress, it activates AMPK, the master energy sensor, which increases glucose uptake in skeletal muscle, enhances fatty acid oxidation, improves mitochondrial biogenesis, and boosts antioxidant defenses. It essentially promotes metabolic flexibility, the ability to switch efficiently between carbohydrate and fat burning. Who is it realistically for? Individuals with insulin resistance, type 2 diabetes, or obesity-related metabolic inflexibility where mitochondrial function is impaired. It also has exercise mimetic potential for sedentary patients or those unable to train intensely. Who is it not for? Healthy, metabolically fit individuals without objective metabolic impairment. It is not a general performance or longevity enhancer at this stage. Avoid inactive infections, certain mitochondrial diseases, or without confirmed metabolic targets. Biomarkers required. HbA1c above 5.7%, fasting glucose 100 mg DL, elevated HOMA-IR 2.5, and ideally indirect markers of mitochondrial stress, e.g., elevated lactate pyruvate ratio if available. Track response via continuous glucose monitoring, repeat HbA1c, and body composition. Risk management. Data from early human trials is encouraging for safety, but long-term experience is limited. Monitor for gastrointestinal side effects. Always pair with dietary, carbohydrate control, and resistance exercise to leverage the metabolic window it opens. Finally, ARA-290, an 11 amino acid peptide modeled after erythropoietin, but without erythropoietic, red blood cell increasing activity. It selectively activates the innate repair receptor, reducing pro-inflammatory cytokine signaling, inhibiting apoptosis in damaged tissues, and promoting nerve regeneration and small fiber repair. It has shown particular promise in painful small fiber neuropathy and metabolic nerve damage. Who is it realistically for? Patients with confirmed small fiber neuropathy, diabetic, sarcoidosis-related, or chemotherapy-induced, where pain, burning, and autonomic symptoms persist despite standard care. Phase 2, data also suggest modest improvements in glucose control and metabolic parameters. Who is it not for? General inflammatory conditions without neuropathy, or individuals with clotting disorders or EPO-related contraindications. Not appropriate as a broad anti-inflammatory without a targeted neuropathic indication. Biomarkers required. Objective confirmation of small fiber loss. Corneal confocal microscopy, skin biopsy, or quantitative sensory testing. Elevated HbA1c if diabetic, and baseline inflammatory cytokines, IL-6, TNF-alpha. Track symptom severity with validated neuropathy scales. Risk management. Clinical trials to date show excellent safety, no hematologic changes or major adverse events. Use defined short courses. Monitor injection site reactions and neuropathy scores. Reserved for cases where first-line therapies have failed. To close this segment, these peptides can matter when their mechanisms directly address a measured deficiency or pathology, visceral fat excess, impaired GH pulsatility, specific tissue injury, mitochondrial metabolic inflexibility, or neuropathic inflammation. But they are adjuncts, never substitutes for foundational work. Nutrient-dense diet, progressive strength training, quality sleep, stress management, and aggressive control of cardiometabolic risks. We've covered the delusions, the real killers, and the few peptides that actually have legitimate mechanisms when used narrowly and under supervision. Now in this 10-minute segment, the peptides that are hype, I'm going to be blunt. Blunt because patients are getting fleeced, risks are being downplayed, and evidence is being ignored in the name of profit and wishful thinking. We're talking about three big ones dominating longevity clinic menus and social media feeds in 2026. Exosomes pushed as the ultimate anti-aging IV drip or injection, so-called stem cell injections without any real medical indication, and random stacking of GLP-1 agonists in people who are already lean or metabolically healthy. These aren't subtle gray areas. They're outright hype machines that prey on fear of aging, promise the moon, and deliver mostly empty wallets and potential harm. First, exosomes in longevity clinics. Exosomes are tiny vesicle cells released to communicate, carrying proteins, RNA, lipids, basically signaling packets. In theory, they could modulate inflammation, support tissue repair, or deliver cargo. Preclinical animal studies show intriguing effects on senescent markers, organ function, or wound healing. But here's the blunt truth. As of 2026, exosomes remain firmly in the hype phase for human longevity use. They're stuck in the trough of disillusionment on hype cycles for cell and gene therapies, years away from maturity, with methodological chaos around isolation, dosing, purity, and consistency. No exosome product is FDA approved for any anti-aging, longevity, or general regenerative claim. Not one. Clinics offering IV exosome infusions for cellular rejuvenation, turning back the clock, or vague vitality are selling unapproved biologics, often at thousands per session. The evidence? Mostly mouse data, a handful of early phase trials for specific diseases like Duchenne or inflammatory conditions, and zero robust human longevity outcomes. Cosmetic exosome facials or microneedling add-ons are exploding in med spas. But even there, it's marketing over medicine. Collagen claims without standardized large-scale proof. Who falls for this? People desperate for a non-invasive fountain of youth. The risk, unregulated sourcing means variable potency, contamination potential, immune reactions, or worse, theoretical oncogenic signaling if pro-growth factors dominate. Clinics rarely track real biomarkers pre-post. They just sell hope. Bottom line, exosomes aren't ready for prime-time longevity. If a clinic is pushing them as a cure-all IV drip, run. They're cashing in on hype, not helping you age less. Next, stem cell injections without indication. This one's even more egregious. Longevity and anti-aging clinics worldwide offer autologous or allogeneic stem cell infusions, often adipose-derived bone marrow or umbilical, promising systemic rejuvenation, reduced inflammation, better energy, longer life. They market it as regenerative medicine for fatigue, cellular decline, or just plain getting older. Blunt reality, there is no solid evidence that indiscriminate stem cell injections reverse aging or extend health span in healthy or mildly declining adults. Zero large-scale, randomized trials support broad anti-aging claims. Some small studies show benefits in specific conditions, osteoarthritis, certain autoimmune issues, but for general longevity, it's speculative at best, fraudulent at worst. Many of these clinics operate in regulatory gray zones or offshore, injecting cells without clear medical need. Risks are real. Immune rejection, ectopic tissue growth, infection, pulmonary emboli from IV delivery, or in rare but documented cases, tumor promotion if cells are mishandled. The FDA has repeatedly warned against unapproved stem cell therapies, noting serious adverse events and no proven benefits for anti-aging. Who are they for? Almost no one in a longevity context without a specific FDA-cleared or trial indication. Not for optimization, not for preventive rejuvenation. If you're healthy or just feeling middle-aged, this is expensive placebo at best, dangerous experimentation at worst. Demand proof, not testimonials, not before-after photos, actual peer-reviewed data for your exact use case. Most can't provide it. Finally, random GLP-1 stacking in already lean patients. GLP-1 receptor agonists, think semaglutide, tirzepatide, are game changers for type 2 diabetes, obesity, and cardiometabolic risk. They reduce appetite, improve insulin sensitivity, promote meaningful fat loss, and cut cardiovascular events in high-risk groups. But in the biohacking longevity world, lean or normal weight people, often already fit, low body fat, are stacking them off-label for anti-aging, inflammation reduction, metabolic optimization, or to get even leaner. Some claim they feel younger, train harder, or reduce age-related joint pain. Be blunt, this is reckless and counterproductive. In lean individuals without metabolic disease, aggressive GLP-1 use accelerates muscle loss. Up to 25-40% of total weight lost can be lean mass, if not countered with heavy resistance training and high protein. Sarcopenia risk skyrockets, especially in older adults. Frailty, reduced metabolic rate, poorer recovery, and higher all-cause mortality linked to excessive lean mass loss. Side effects amplify without obesity buffer. Nausea, GI misery, potential gallbladder issues, pancreatitis risk, and, in stacking with other compounds, hypoglycemia or hormonal disruption. Emerging reports show older biohackers using them for anti-aging benefits like less inflammation or